Okay, Assalamualaikum dan salam sejahtera. My name is Muhammad Fadhli bin Fazil. I'm from OUM Al-Star. Today, I would like to present my case study for the subject NBCP2424, Clinical Practice Pre-Hospital Care and Ambulance Service. Okay, my case study is Community Acquired Pneumonia, CAP. Okay, introduction. Community acquired pneumonia (CAP) is a leading cause of death in the world and the sixth most common cause of death in the United States. The Infectious Disease Society of America (IDSA) defines CAP as an acute infection of the pulmonary parenchyma that is associated with at least some symptoms of acute infection, accompanied by the presence of an acute infiltrate on a chest radiograph or auscultatory findings consistent with pneumonia, such as altered breath sounds and or localized rales. Okay, CAP is a common illness and can affect people of all ages. Usually spread by droplet infections, and most cases occurs previously healthy individual. Okay, selalunya jangkit melalui droplet lah, dia spread dengan droplet. Okay, several factors can impair the effectiveness of local defense and predispose to CAP. Once the organism settles in the alveoli, an inflammatory response ensures. Bila organism bakteria yang masuk dalam alveoli, dia berlakulah inflamasi, menyebabkan pneumonia lah. Okay. In pneumonia, the lungs become filled with pus and this makes them stiff. Okay, pneumonia ni kita punya paru-paru dia penuhi dengan danau, dengan pus. So the patient breathe fast and stiff lung. Patient akan menafas laju lah, teknik dengan stiff lung. As pneumonia become worse, the lungs become even stiffer and they do not expand properly. Nah, kita tak boleh nak expand sebab paru-paru kita dipenuhi dengan danau. Severe pneumonia has a lot of pus in the lungs, so the lungs are very stiff. Okay, dia punya paru-paru dia penuh dengan danau, dengan alveoli dah. Ni alveoli isi dengan penuh dengan danau. Okay, dia punya penyebab dia adalah bacteria are the most common etiological pathogens of CAP. Traditionally been divided into two groups designated, iaitu typical dan atypical. Typical ialah Streptococcus pneumonia, Haemophilus influenza, Staphylococcus aureus, Group A Streptococci, Moraxella catarrhalis. Ini jenis typical lah. Okay. Atypical ialah Legionella species, Mycoplasma pneumonia, Calmodophilia pneumonia. Okay, chief complaint ataupun sign and symptom. Okay, yang pertama, chest pain when you breathe or cough. Okay, patient yang ada CAP selalu menunjukkan sakit dada, chest pain bila ada nafas ataupun batuk. Batuk sikit dan sakit kat dada, bahagian dada. Okay, yang keduanya, confusion or change in mental awareness. Okay, selalu dia akan jadi confused. Selalu terjadi pada orang tua lah, patient yang berumur 65 and older. Jadi confusion pada tahap yang teruk lah, pneumonia pada tahap yang teruk selalu macam ni. Okay. Yang ketiga, fatigue, rasa keletihan. Okay. Yang keempat, fever, sweating and shaking chills. Lah ada demam, ada infection kan kat bawah kita, ada demam, ada berpeluh dan rasa seram sejuk. Okay, yang kelima, rasa nausea, vomiting dan diarrhea. Bila ada infection, ada diarrhea. Boleh jadi diarrhea untuk patient pneumonia dan rasa muntah dengan loya. Okay, yang keenam ialah sesak nafas, shortness of breath. Bila paru-paru kita penuh dengan pus, kita rasa susah nak bernafas. Okay. Ini adalah demographic data. We call patient as Mr. D. Okay, dia punya RN SP0005564, sex male, age 48 years, race India, dia berkahwin lah, social status married, pekerjaan dah lorry driver, weight 69 kg. Okay, dia masuk dekat emergency department bahagian red zone lah. Date of admission 16 September 2021. Okay, ambulation independent. Okay, dia punya social history, activity, daily living independent, working as a lorry driver, dia seorang perokok, active smoker lah, dan non-alcoholic. No history of using drugs or taken traditional medication, and no non-allergic. Okay, demographic. Okay, Mr. D is the second from 5 siblings. His father has diabetes and hypertension. Ayah dia ada kencing manis dengan darah tinggi. The mother has no known medical illness. His first brother has bronchial asthma since childhood. The other siblings have no medical or surgical history. Okay. Previous medical history. Patient ada hypertension sejak 2016. Okay. On tap perindopril 4 mg OD. Patient juga ada chronic obstructive pulmonary disease COD for 3 years since 2018. Okay, initial assessment. At about 8:30 AM, the Sultan Abdul Halim Hospital Call Center received a call from Medical Emergency Coordinator Center MECC, Hospital Sultan Abaya, HSB, saying a patient had complained of shortness of breath at his home. A pre-hospital care ambulance team was dispatched to the scene. Okay, dalam 8:30 pagi macam tu, terima panggilan daripada Hospital Sultan Abaya mengatakan ada patient mengandung sesak nafas lah kat rumah, dan pre-hospital care ambulance team dispatched to the scene. Okay, upon arrival at the patient's home, Mr. D home, no any of hazardous material was seen, and the victim was there, lying on a bed with semi-foulous position in the room. The patient's wife tells Mr. D having shortness of breath and unable to breathing spontaneously and having cough and fever. He also continued to have diarrhea and vomiting. Okay. He denied any leg swelling, tak ada edema lah, tak nampak kaki bengkak. Autopnea on left-sided substernal chest pain. He had no known drug allergies. Initial assessment was done to get general impression of the patient. Okay, check his mental status or level of consciousness. ABPU lah, alert, verbal, pain, unresponsive. Okay, Mr. D was open her eyes when his name was called. Kita panggil tu, dia menyebut lah, dia buka mata lah. Okay, no change in physical appearance. For the response, the verbal patient was confused and restless. Nampak patient dia confused sikit lah. The Glasgow Coma Scale is 14/15. Dia cakap pun 2-3 patah perkataan lah. Lepas tu dia pernah deep sneak lah. Okay, pulse oximetry show oxygen level is 88. Okay, oxygen level dia rendah juga 88%. Oxygen face mask was given to maintain oxygen supply. Kita bagi face mask lah. Oxygen saturation 93 on face mask oxygen. Okay, ni masa dalam bulan lah, kita bagi oxygen face mask lah. Lepas tu oxygen di pick up balik 93 lah. The respiration rates are 33 per minute. The blood pressure is 160/83. His temperature was 38.8. Ada temperature, and heart rate is 130 beats per minute. Okay. Okay, ni dari bulan. Kita repeat initial assessment. Assess the level of consciousness. Open her eyes when his name was called. Okay, kita panggil itu, dia buka mata. And check for airway, breathing, and circulation. Assess the vital signs. The patient was in moderate respiratory distress and was seen using accessory muscle of respiration. Dia susah nafas, nampak pakai dia punya accessory muscle. Auscultation revealed decreased breath sound in the same area. Presence of crackling sound. Dia ada crackling sound. The intravenous bronchola was inserted in the ambulance. Okay, discussion on medical surgical management of the patient. Okay, ambulance arrived at the emergency department. Patient confused and restless but respond to call. Look tachypnea. Talk in words, GCS 14/15. Difficulty for breathing. Use of accessory muscle for breathing. Chief complaint is shortness of breath. Okay, sent to red zone for the treatment. Okay, vital sign ambil pasal kat red zone. Vital sign was checked, blood pressure high, 160/90 past 110 per minute. Temperature is 38.5 and SpO2 was 93 under 5 liter face mask oxygen. Okay. Okay, kat next one kita buat detail physical examination. Okay. Okay, eyes, inspect the color and pupils. Inspect around the eyes. There was a pale in color. Nampak ada pucat sikit. Inspect the color, lips dry and look pale and mild bluish due to reduced oxygen. Okay, nampak ada kebiruan sikit sebab oksigen kurang dalam badan. Nose, nasal flaring. Tongue white in color and dry, no central cyanosis of tongue. Inspection for determine endemic and cyanosis symptom. Neck to form enlarge of lymph nodes and looks for distant jugular veins. Respiratory, cause breath sounds, rails, mild bronchi heart present. Okay, extremities, look at fingers for cigarette tar stains and inspection. Lower extremities for detect peripheral edema. Tengok bahagian kaki pun untuk detect edema. Okay, skin look dry and pale sebab patient nampak ada ciri diarrhea dan vomiting. Okay, look dry and pale. Diagnostic test. Okay, diagnostic test macam misalnya kita buat pneumonia, selalu untuk pneumonia kita buat chest x-ray, ya. Lepas tu kita buat ECG, various blood investigation, ABG, RP, LFT and FBC. Okay, chest x-ray dah. This study chest x-ray reveal a lower right lobar type pneumonia without an effusion. The gold standard for diagnosis of CABP is the chest x-ray. One pneumonia is suspected based on history of present illness, subjective symptoms and physical exam. The clinician should obtain a standard chest radiograph with PA and lateral views. Okay, ini dia punya ECG, nampak ada sinus tachycardia sikit lah. Okay, no ischemic changes. According to Smith and Hood, sinus tachycardia is a physiologic response to an underlying condition and not an arrhythmia process. So, treatment must be directed at the underlying cause. Okay, ini dia punya blood investigation. Purpose of ABG was taken to Mr. D is to monitor pH and level of oxygen and carbon dioxide, to identify hypoxia and increase carbon dioxide level. Okay, determine degree and severity of disease process. Most often PA2 is decreased and PaCO2 is increased. pH so acidotic, mild respiratory acidosis secondary to pneumonia. Okay, dia punya renal profile dia normal lah, result RP dia. Okay, ini dia punya result ABC dia. Result ABC kita ambil untuk to investigate the anemia, cause of bleeding, to know about infection and bleeding status. Okay, dia punya result ABC nampak ada macam infection sikit lah. Dia punya white blood cell nampak increase sikit, nampak yang normal sikit lah. Okay, dia punya LFT normal. Okay. Okay, medical officer plan to start treatment for this patient. His treatment include slowly intravenous injection augmentin 1.2 mg TDS via drip. Okay, then the medical officer start nebulizer salbutamol hourly and nebulizer complement 4 hourly. Okay, IV hydrocortisone 1 mg TDS. Salbutamol is off the bronchodilator short acting agonist that reduce shortness of breath, wheeze and improve breathlessness. Okay, tablet paracetamol given 100 mg step due to temperature high lah. Mr. D was also given an IV drip nose line 4 pints over 24 hours because his condition appeared to be dehydrated. ED medical officer refer Mr. D to medical officer for medical department. Dekat refer kat bahagian medical to review this patient for continued treatment and management in ward. Mr. D look comfortable after all treatment given. Send patient to medical ward and then continue all treatment lah kat ward. Okay, identification, clinical diagnosis and intervention for the patient. Okay, yang pertama adalah ineffective airway clearance. Diagnosis, Maintaining a pattern airway has always been vital to life. Okay, possibly evidence that shows by Mr. D. Statement of difficulty of breathing. Dia ada mengalami sesak nafas. Change in death rate of respiration. Use of accessory muscle. Okay, intubation untuk patient kita pro up dia punya bed lah. Pro up the bed at least 45 degree for Mr. D. Can make easily to breathe instead of lying down on bed. Okay, kita bagi oxygen 5 liter via face mask to maintain the airway pattern. Okay, diarrhea and vomiting. Mr. D had diarrhea and vomiting. Possibly evident that shown by Mr. D. Okay, the dry mouth, lips and eyes, peeing a little, and fever than 4 times a day. Intubation dia, kita bagi intravenous drip for pine normal saline given over 24 hours. Okay, ketiganya impaired gas exchange. Diagnosis: impaired gas exchange related to altered oxygen supply, obstruction of airways by secretion, air trapping. Possibly evidence shown by Mr. D is dyspnea, abnormal breathing, confusion, and restlessness. Okay, intubation then assess and record respiratory rate. Deep suctioning may be required when cough is infective of expectoration of secretion. Okay, yang keempat, productive frequent cough. Okay, Mr. D have productive sputum and frequent cough. Possibly evident frequent cough with whitish sputum. Intubation for the patient is a chest percussion was performed for Mr. D due to frequent cough and productive sputum. Okay, yang kelima, fever, chills and rigor. Mr. D body temperature is quite high at 38.5 degree. Mr. D has a fever and chills and rigor. This is a sign that Mr. D has a lungs infection. Possibly evident, Mr. D had chills and rigor. Temperature was high. Okay, intervention for the patient. Mr. D was given 1 gram of paracetamol tablet. This is intended to reduce his body temperature. Paracetamol acts as antipyrexia. Okay, intravenous drip of normal saline 4 pints over 34 hours also given because his condition appeared to be dehydrated. Okay, lastly, conclusion. Okay, it can be concluded that this case study is about the patient Mr. D that had community acquired pneumonia. Based on the above explanation, myself has present about managing this patient at the triage and how to take care of this patient at the emergency department. Mr. D was brought to emergency department by ambulance and admitted to red zone due to shortness of breath. Initial assessment, all blood investigation, chest X-ray, and vital signs that were done for Mr. D shows having community acquired pneumonia and need immediate treatment for stabilize his condition. Okay, thank you.